Red light's on.
You're on.
Our group was charged with developing an alternative to the GMP. The first thing we did was immediately abandon that objective in lieu of a different objective. Our objective is embodied in the fact that we think the current document calls upon physicians to perform in ways prohibited by circumstances or systems which are beyond their control. We suggest an assessment of the current GMP items to determine those which are under the physician's control and those which are not. There are two elements that we suggested require modification. The first is that the current payer system, fee-for-service or encounter fee, should be modified to an outcomes-based payment.
So how do we do?
The second is that information systems which provide adequate feedback on outcomes and performance should be developed. This is all under the component which we defined as external. Then we had an internal environment, and our comment there was that the current GMP calls upon physicians to make fundamental changes in their performance without defining appropriate education and assessment tools to implement those changes. Examples. Number one, improved effective communication. Communication between physicians, within systems, with other healthcare personnel. And then number two, cultural change, which is far and away the biggest challenge. Under cultural change, we listed assessment of performance and value, acceptance of the fact that physicians are accountable, commitment to continuous quality improvement, the need to embrace teamwork, continuity of care within the new paradigm of practice with the younger generation, management of conflict of interest, and commitment to the health of populations. We use the term public health, but the concern here is that we deal with the health of populations. Now, in the discussions that followed our initial work, the questions raised were, can physicians modify the payment system without external assistance? Particularly someone from the Canadian system indicated that the physicians there have more input than perhaps we do in the United States. A second question was, how would outcomes-based payment reward hospital-based physicians? Third question was, or the third comment was, that outcomes must be more than simply utilization. And the fourth was, who manages the cultural changes which we have listed in our internal assessment? Thank you.
Good work, Clarkson.
A star is born.
I'm telling